Hello, my name is Tania. I am an anesthesiologist in Hospital Pediátrico de Coimbra, Portugal, and I'm here to talk to you about anesthetic management of organ donors. This session is organized in three main subjects. After a brief introduction, we will talk about anesthesia for living donors, followed by management of brain death donors in the ICU and in the operating room. We will discuss the main differences and similarities between adult and pediatric donors, and finally some words about donation after circulatory determination of death. After this session, the listener should be able to know the major targets in the management of each type of organ donor. Organ donation has allowed a high number of patients to receive a new opportunity in their health. The biggest obstacle for organ transplants is the shortage of suitable organs. The discrepancy between need and supply is wide and increasing, and of course led medicine in a search for solutions to consider different types of donors and to extend donor inclusion criteria, which also brings new challenges. We can define three major types of donation: donation in the living person, donation after neurologic determination of death. Here you have death by neurologic criteria with intact circulatory function, and it is the most common type of donation. And finally, donation after circulatory determination of death. It is the donor that does not meet the criteria of brain death, but has not hope of any sort of neurologic recovery. Death is determined using circulatory criteria: permanent absence of breathing, circulation, and responsiveness. Anesthesia for organ procurement is required for living donors or after brain death, but not for donors after cardiac death. In the living donor, we want to assure the safety of the donor and the viability of donated organs. In brain death donation, we have our focus in preserving donated organs. Let's talk about anesthesia for living donors. The two major transplants in living donation are kidney and liver transplant. Organs from living donors have better graft and patient survival rates for the recipient than do organs from deceased donors. Living donors are physiologically and hemodynamically normal. The graft is not exposed to ischemic changes associated with brain death or cardiac death as it happens in deceased donors. Transplantation can also be scheduled electively with both donor and recipient surgeries coordinated at the same time and place. This minimizes cold ischemia time for the donated organ. Living kidney donors are in good health with normal kidney function and without chronic illness or clinically significant hypertension. Donor nephrectomy does not seem to increase long-term mortality or end-stage renal disease in a general donor population. Most olive kidney donations are performed by laparoscopy. It's important for us to know some general considerations of surgical technique. So we have the possibility of laparoscopy versus open nephrectomy. Advantages of laparoscopic nephrectomy include significantly less pain and a shorter recovery period in hospital stays without increased complication rates. Each technique demands different anesthetic concernings that we will discuss. The anesthetic management is adapted to the surgical technique. Laparoscopic nephrectomy is usually managed with general anesthesia, and open nephrectomy with general anesthesia alone or combined with an epidural technique. To induction and maintenance of general anesthesia, we can use inhalation agents or retiva technique. Neuromuscular blocking agents are employed with either technique to reduce intra-abdominal pressure and ensure good renal perfusion. High intra-abdominal pressure reduces venous return and has been associated with postoperative renal dysfunction. The major difference in the donor nephrectomy compared to the anesthetic management of a conventional nephrectomy is the protection of the donor kidney. The major risk to the kidney that is being transplanted is ischemia, which can be associated with delayed graft function in the recipient. It is important to avoid even mild ischemia of the kidney, so it is very important to maintain intravascular volume, adequate mean arterial pressures, and avoid high intra-abdominal pressure. It is possible to obtain optimal renal perfusion, maintaining low carbon dioxide insufflation pressure under 15 during laparoscopic nephrectomy, expanding intravascular volume, administering mannitol and furosemide to achieve a good urine output, avoiding vasopressors, and during laparoscopy nephrectomy, changes in pulmonary function occurring with insufflation of carbon dioxide may require modifications in mechanical ventilation settings, so mild hypercapnia can be tolerated to improve tissue oxygenation and perfusion. Risks to the patient during nephrectomy include cardiopulmonary and gastrointestinal complications, bleeding, and pain. Incidence and severity may depend on the type of nephrectomy. After open nephrectomy, pulmonary complications can occur in an early postoperative period due to moderate to severe pain, particularly with a subcostal lateral incision. Pain limits the patient's efforts to breathe, to cough, and to move, potentially resulting in atelectasis and pneumonia. That is why it's so important to choose the right postoperative analgesia technique. So what can we do to control pain? In open nephrectomy, we have a few options. We can use epidural anesthesia with local anesthetics alone or combine with opioids. A patient-controlled analgesia of opioids alone or in combination with regional anesthesia techniques like a paravertebral block or intercostal blocks. Another possibility is to do a rector spine plane block, which has shown very good results in pain control in combination even with minor analgesia. You can choose single shot or continuous perfusion with good results. Mild or moderate pain after laparoscopic nephrectomy may result from the port insertion site, the abdominal incision, pelvic organ manipulation, diaphragmatic irritation, and ureteral colic. We also have different options, but it is important to combine our endovenous multimodal analgesia with regional anesthesia. Pregabalin has been showed good results in the multimodal approach of pain. Don't forget that it is very important to avoid anti-inflammatory drugs due to their potential for nephrotoxicity. Now let's talk about living donor liver transplantation, which provides a solution to expand organ availability. Advantages include, among others, optimization of timing for transplantation and minimal cold ischemia time. It has also been associated with lower recipient mortality compared with waiting for a deceased donor. Living donor liver transplantation has become an accepted practice in pediatric transplantation. Improvements in surgical techniques have minimized the risks of left lateral segmentectomy to the donor, and recipient outcomes are now excellent. Adult living donor liver transplantation typically involves transplantation of the right lobe. Right lobe hepatectomy confers a higher risk of morbidity and mortality to the donor. Several ethical concerns regarding living donor liver transplantation relate to the potential for donor morbidity and mortality. While mortality rates among donors are low, early death and acute liver failure can occur. In addition, donors are at risk for significant morbidity following donation. The procedure does not differ too much from a conventional hepatectomy. The safety of the patient is the most important issue. Major goals of anesthesia are the reduction of intraoperative stress, reduction of hemodynamic disturbances, and control of bleeding and coagulation, maintaining a good metabolic status and normal temperature, and of course reduction of perioperative pain. Anesthetic management has some points of controversy that have been discussed over the years. The use of epidural anesthesia in combination with general anesthesia is controversial. If cited appropriate, has been shown to achieve good analgesia in patients undergoing major abdominal surgery. However, its use in liver recession is controversial, as postoperatively patients may suffer coagulopathy, with risk of developing an epidural hematoma. Although this complication is extremely rare, it can be catastrophic. As a sizable part of the liver is removed and the remnant liver sustains some degree of injury, anesthetic drugs that are chosen, and mostly intravenous analgesic and opioids, should have minimal impact on liver blood flow and postoperative liver function. One of the strategies used to help in the hemodynamic management is keeping central venous pressure under or equal to 5, as it may reduce blood loss and graft congestion. After liver resection, central venous pressure can be normalized with fluids. However, it is important to avoid fluid overload after the graft is removed because it may result in congestion of the remnant liver. So most donors are extubated immediately post-operatively unless the surgery has been very long, the patient has received a massive blood transfusion, or there had been a longer than expected intraoperative hemodynamic instability. The most common post-operative complication is pain or transient hepatic dysfunction, coagulopathy, and hemorrhage, portal vein thrombosis, deep vein thrombosis, and pulmonary embolism. Right hepatic lobectomy is associated with higher postoperative later complications because of its surgical complexity and larger resect volume. Some series report 40% of donors with complications. Infection is the most common, followed by biliary complications, leading to prolonged hospital stays and the possibility of further surgeries. Postoperative pain control can be achieved by patient-controlled analgesia via an intravenous or epidural catheter. Epidural analgesia provides better pain control, less sedation, and decreased incidence of respiratory infection and ileus compared with intravenous patient-controlled analgesia. As it was already said, preoperative placement of a thoracic epidural catheter is completely avoided in some centers because of the development of postoperative coagulopathy with decreased platelet counts and increased prothrombin time. Finished our first subject, we will now talk about the management of brain death donors. Management of potential donors is as complex as that of any other patient in an ICU. Following neurological death, circulatory collapse occurs within hours if there is no medical intervention. Management of the potential organ donor involves the use of conventional therapeutic and supportive measures to reverse or control the physiologic changes that occur after brain death. This process requires a judicious balance of interventions to assure the successful preservation of multiple organs. An active donor management is believed to improve the retrieval rate. Regardless of the initial cerebral insult, the endpoint of neurological death is complete ischemia and irreversible loss of brainstem function. Neurologic death unleashes a cascade of autonomic, endocrine, hematological, inflammatory, and cardiorespiratory responses that threaten organ viability. Understanding and anticipating these events will allow for optimal management of the patients. The final event in neurological death is often necrosis of the parasympathetic nuclei in the medulla oblongata and unchallenged sympathetic activation, leading to a massive release of catecholamines. This is known as autonomic storm or hyperdynamic phase. During the autonomic storm, elevated levels of catecholamines lead to increased heart rate, mean arterial pressure, cardiac output, and massive peripheral vasoconstriction with a rise in systemic vascular resistance. The autonomic storm is closely followed by a phase of hemodynamic compromise, which presents the greatest risk to donor organs. The autonomic storm is short-lived because the spinal cord becomes ischemic and it stops the sympathetic overdrive. As a result, heart rate, blood pressure, and myocardial contractility decrease. Untreated hypotension results in coronary artery hyperperfusion and further myocardial tissue damage. Hemodynamic instability due to myocardial dysfunction and loss of systemic vascular resistance results in hypoperfusion of potential donor organs, and it is the greatest cause for organs becoming unsuitable for transplantation. Autonomic storm is typically transitory, so hypertension and tachycardia should be treated with short-acting adrenergic antagonists such as esmolol. Subsequent hypotension is usually first managed by fluid resuscitation with either normal saline or balanced salt solution. Starch-based colloids are associated with delayed graft function. They should not be routinely used. When hemodynamic instability remains after adequate fluid resuscitation, vasoactive and/or inotropic agents should be considered. Dopamine is a drug of choice in this setting. For patients who remain hypotensive with a MAP under 60, despite appropriate fluid replacement, it is possible to initiate infusion of low-dose vasopressin, which is effective in treating vasodilatory shock and reducing the need for catecholamines for blood pressure support, in addition to treating diabetes insipidus if present. For persistent hypotension, the next step is to determine whether it is due to low systemic vascular resistance or myocardial dysfunction. The optimal vasopressor for deceased organ donors with intact myocardial function has not been determined. Traditionally, dopamine has been the first choice for hemodynamically unstable donors, and some evidence supports a benefit in improving post-transplant kidney allograft function. However, comparative trial data are lacking, and practice patterns have shifted in favor of using norepinephrine or phenylephrine for severe vasoplasia. Norepinephrine used in high doses is associated with post-transplant complications, including cardiac graft dysfunction and recipient mortality. If a pulmonary artery catheter is placed or other hemodynamic monitoring devices are available, the following donor management goals are suggested, as you can see in the presentation. These criteria were suggested for adult patients and are also appropriate ranges for most older children or adolescents who are potential donors. Proceeding with our pathophysiological study, we see that pulmonary edema may occur during the autonomic storm. It is caused by systemic vasoconstriction and pulmonary volume overload, leading to pulmonary edema. Additionally, neurological death predisposes patients to pulmonary infection for several reasons. First, neurologic death abolishes the Koch reflex, which leads to changes in mucus clearance and atelectasis. Second, the site mechanism, important in maintaining lung volume, is absent in neurological death. And finally, the larynx and pharynx are atonic and non-functional. In our strategy, we will try to adjust our ventilation to the known pathophysiology, having always in mind a protective ventilation program. The initial setup is typically in volume control to assure tidal volume in the presence of high pressures. Then we will do adjustments to the initial settings, rate, volume, pressure profile, so that we can achieve a plateau pressure under 25. The same should be done with oxygen and positive and expiratory pressure to reach the best relation between them. Antibiotics that were started in the ICU must be continued in the perioperative time. Brain death is also associated with the disturbances of synthesis, release, and use of cortisol, thyroid hormones, antidiuretic hormone, and insulin. The development of central diabetes insipidus can result in severe fluid and electrolyte abnormalities. Involvement of anterior pituitary function in brain death can lead to deficiencies in T3 and T4, adrenocorticotropic hormone, thyroid-stimulating hormone, and human growth hormone. Hyperglycemia is common because of insulin decreased concentrations and increased insulin resistance. Early studies suggest that thyroid hormones replacement may increase the number of organs transplanted per donor. However, the benefits of thyroid hormone supplement cannot be confirmed by recent studies. Exogenous replacement of antidiuretic hormone in brain death donors has been shown to improve graft function in kidney, liver, and cardiac recipients. Recently, a hormonal resuscitation package with steroid, vasopressin, and insulin has shown to improve not only organ retrieval rates, but post-transplant patient and graft survival. After neurologic death, the hematocrit may rise acutely within minutes. This is most likely due to acute vascular depletion and transcapillary fluid shifts. The hematocrit may fall later, most likely because of fluid redistribution, hemolysis, and the dilutional effect of aggressive fluid resuscitation. Coagulation disturbances can occur during and after the progression to brain death. An hypercoagulable state can arise as large amounts of prothrombotic agents are released into the circulation following the initial cerebral insult. 1/3 of brain death donors present with coagulopathy, which is thought to be caused by the release of tissue thromboplastin from brain tissue. Hematologic management aims to correct abnormalities in coagulation and to correct hemoglobin values so that a good oxygenation is always assured. Renal vasoconstriction is common in the setting of hypotension. Prolonged renal vasoconstriction can lead to acute kidney injury and renal failure. Diabetes insipidus leads to polyuria and can also contribute to hypotension. When vasoconstriction is not needed, desmopressin is the drug of choice. Although liberal fluid administration may benefit renal grafts, recent guidelines support the role of euvolemia in multi-organ donors. Polyuria and hemostatic changes can cause rapid changes in potassium, magnesium, and calcium, leading to cardiac arrhythmias, so we have to monitor electrolytes in order to anticipate cardiac arrest. These are the reference values and parameters that we should consider in our electrolytes evaluation. It is important to know that donor hypernatremia is associated with poor transplant outcomes in liver and heart transplants. As it was said before, specific donor management goals have been developed to guide clinical care, including minimizing inotropic use, normalization of blood pressure, oxygenation and ventilation parameters, correction of electrolyte disturbances, and controlling fluid balance. Studies in adults have demonstrated that these goals improve chances of organ recovery and graft function post-transplant, and these goals are also applicable to pediatric organ donor management. Specific recommendations in the literature about cardiovascular system suggest the continuous use of invasive central venous and arterial pressure monitors in all potential organ donors, regardless of age, that fluid intake and output should be monitored and recorded, and that children under the age of 10 are commonly managed without pulmonary artery catheters. In older children, pulmonary artery catheters may be used according to medical decision. Hypotension is almost universal after neurologic death and is typically managed with a combination of fluid administration to restore circulating volume and drugs with inotropic and vasopressor effects. Sometimes fluid challenges are necessary, but we should remember that the use of synthetic colloids is discouraged as they can potentiate renal failure. Glucose-containing fluids should also not be used for volume expansion because these may promote osmotic diuresis. Serial measurements of lactate can help assessing the adequacy of oxygen delivery to the tissues. Monitoring of mixed venous oxygen saturation may also be beneficial in determining adequate cardiac output. If lactate and SVO are within normal ranges, the clinician may permit lower blood pressures and thus minimize use of vasopressors. Arrhythmias are common and may be caused or exacerbated by electrolyte disturbances, inotropes, hypovolemia, hypothermia, hypoxia, acid-base disturbances, and myocardial ischemia. Bradyarrhythmias should be treated only if they are associated with hypotension. Bradyarrhythmias will not respond to atropine in patients who have progressed to brain death. In patients who require treatment for bradycardia, epinephrine or dopamine are preferred agents. Isoproterenol may be considered for this use, but can cause a drop in blood pressure. Patients frequently develop hypernatremia following neurological death. This may be caused by diabetes insipidus and/or sodium administration for treatment of increased intracranial pressure during cerebral resuscitation. Hyperglycemia may be caused by catecholamine release or exogenous inotropes, steroids, or decreased or absent cerebral metabolism of glucose. Finally, but not least, the recommendations about ventilation. All potential organ donors will require mechanical ventilation to maintain appropriate ventilation and oxygenation. A cuffed endotracheal tube should be used to minimize the risk of aspiration in children, regardless of age. Ventilator settings should be tailored to maintain adequate oxygenation, normalize ventilation, and prevent atelectasia. Oral care, regular suctioning of hypopharynx, and elevation of the head of the bed will help reduce the risk of aspiration and infection. And ventilator strategies and alveolar recruitment maneuvers may be necessary to improve oxygenation by reducing atelectasis. We have studied the consequences of brain death in the adult and pediatric population, and now we are ready to prepare everything for organ procurement. In the pre-anesthetic setting, make sure appropriate amount of cross-match blood are available. Previously discuss the dose of heparin with the procuring team and prepare it. Be also prepared to change or upsize the tracheal tube per surgical request if there's lung donation, start vasopressors if necessary, manage hyperglycemia with insulin, have fluid warmers, administer appropriate amounts of crystalloids and resuscitation drugs, continue antibiotics and all the therapeutics that the donor was doing. Is anesthesia important in brain death? Yes, it is. The brain death organ donor usually has a functioning spinal cord and thus may exhibit unregulated spinal reflexes in response to stimulation. Anesthesia is used to manage reflex sympathetic and motor responses. What agents do we have? We have volatile anesthetics, isoflurane, desflurane, sevoflurane, and they effectively attenuate the reflex sympathetic response to surgical stimulation in brain death donors, likely with the same dose response as normal patients. It's reasonable to administer these agents in doses around 1 minimum alveolar concentration. We also have neuromuscular blocking agents. Non-despolarizing blocking agents are administered to prevent uninhibited muscle reflexes in response to surgery. They should be administered in doses that result in deep neuromuscular blockade. A temperature regulation should be done, as also as management of anticoagulation. The anesthesia clinician will be asked to administer the agreed doses of heparin several minutes before aortic cross clamp. Adequate anticoagulation is essential for organ procurement, so heparin should be administered via central venous catheter if one is in place. Once the heparin had time to circulate the aorta, is cross-clamped. Methylprednisolone should not be given until after blood has been collected for tissue typing. When lung is a potential donor organ, our key goal is preventing in situ thrombosis and vasospasm and stabilizing the lung for static cold storage. There are two main strategies where the anesthesiologist may participate. The first is the use of pharmacological additives, and the second is lung inflation with an oxygen mixture during the ischemic period, which appears to protect the lung, but scientific information regarding ideal oxygen concentration and inflation pressure is limited. After finishing the management of the brain death donor, we are now going to talk about donation after circulatory death. DCDD has been increasing in the last 10 years as a response to the lack of organ availability for transplants. The first classification of donation after circulatory death was found in Maastricht in 1995 in an international meeting. Since then, the classification has suffered some changes, and in 2016 was present the last modified classification according to the evidence that has been rising. DCDD can be classified in uncontrolled or controlled. The patients that can eventually become potential donors belong generally to categories 2 and 3. 2, which is a witnessed cardiac arrest with unsuccessful resuscitation, uncontrolled DCDD, and 3, where there is a planned withdrawal of life-sustaining therapy, which is a controlled DCDD. The main concern in DCDD is how to manage the consequences of warm ischemia in donors' organs. Warm ischemia in uncontrolled DCDD is the interval of time between the circulatory arrest and cannulation to organ preservation. If we add the partial times, we conclude that total warm ischemia time is between 120 and 150 minutes. Uncontrolled DCD can only occur in centers where facilities for organ perfusion and retrieval are at immediate hands. For logistic reasons, uncontrolled DCD is usually restricted to kidney-only retrieval. Controlled DCDD occurs when organ donation is desired for a patient who does not meet neurologic criteria for death, brain death, but has no hope of viable recovery, and the decision has been made to withdraw life-sustaining treatment, patients with stroke, cardiac arrest, or multiple trauma. Potential donor patients are ordinarily expected to expire within a short amount of time after discontinuation of life support, about 60 minutes. Withdrawal of life support is best performed in or near the operating room, with the transplant teams ready nearby to minimize warm ischemia time. Ideally, warm ischemia time should be no longer than 60 minutes. If the patient does not expire after 60 minutes, which happens in 20% of the cases, the patient must be returned to the intensive care unit. After meeting criteria for determination of death, a no-touch period is necessary. In the past years, in most countries, a period of 5 minutes has been adopted by medical societies and authorities, although depending on the jurisdiction, a range for 2 minutes to 20 minutes has been reported. No-touch period is followed by reinitiation of ventilation and hemodynamic support and administration of heparin and pharmacological agents for procurement. Organs for controlled DCD donors are exposed to a greater duration of warm ischemia compared to those from uncontrolled DCD. Warm ischemic injury in controlled DCD has the biggest risk for primary graft failure, delayed graft function, and other ischemic complications. Despite an increased incidence of poor initial allograft function, some centers have reported long-term survival rates of kidneys from DCDD comparable with kidneys recovered from heart-beating and living donors. Initial experience suggests that this approach can also be used for liver and lung transplantation if warm ischemic time is minimized. The contribution of DCDD to overall deceased donor numbers differs internationally. Differences in medical practice, public attitudes, legal issues, and economic resources will influence the practice of DCDD worldwide. The anesthesiologist can be part of this process in different times of its progression, in the pre-hospitaler setting, in the emergency room, in the intensive care, in the operative room. The fact is that at some point there's the possibility of conflict of interests. Above all, is the ethic of our behavior and identity that define the choices we make daily, the act of withdrawal support from a critical ill patient to become a DCD donor must be very well regulated. So our presentation is finished. And do you have any question? If there is any doubt or issue which we need to clarify, just send us an email and we will try to do our best to help.